Now, without further delay, let's begin today's event, sponsored by Verato and hosted by Health Data Management. I'd like to introduce your moderator for today, and that is Mike Perkowski. Mike, you have the floor.
Very much. Ladies and gentlemen, welcome to today's web seminar. We're glad that you could take a little bit of time out of your busy days to learn a little bit more about this topic, about how poor patient matching impedes innovation. We're fortunate today to have two featured speakers who will talk about this topic in some depth and who will answer your questions at the back end of our program in the Q&A part of today's program. One of our featured speakers is Todd Stottlemyer, CEO of CNSI, a Rockville, Maryland-based health IT solutions firm. He's the former CEO of the Inova Health Systems Center for Personalized Health, which includes the Inova Shar Cancer Institute, the Inova Translational Medicine Institute, and other programs on the new Inova campus. He previously was Chief Executive Officer at Essentia, an information technology company, and before joining Inova, he was President and CEO and a member of the Board of Directors of the National Federation of Independent Business. Todd's going to be joined as well today by Mark LaRow, Executive Officer at Verato. Verato is a leading provider of cloud-based patient matching and master patient index services powered by referential matching technology. He formerly was at MicroStrategy, a business intelligence software provider. Spent 14 years there where he was the Executive Vice President of Products responsible for product strategy, product marketing, and competitive intelligence. Before MicroStrategy, he was at Ernst & Young for 17 years. He left as a partner responsible for all technical consulting in the eastern region of the United States. So between Todd and Mark, we have a lot of expertise to share here today. I'd like to get going and turn our program over to LaRow of Verato. Mark, the floor is now yours.
All right, thanks, Mike. I appreciate the introduction. Hi, everybody. Thank you for spending some time with us this afternoon. We've got some interesting information teed up for you here. We'll start off just by doing a quick introduction of Verato, the company, and CNSI, so that both Todd and I have a chance to give you a sense of what our backgrounds are and where we come from. But then with respect to the material itself, we want to convey to you three important messages. One is that there is an imperative for innovation in healthcare today. It's no longer an option. And we see this across all of our providers doing many different initiatives. They fall into a couple of big categories, all of which are now making it to the C-suite for consideration as to how it's going to make hospitals more competitive and deliver better care at lower cost. So very important. Typically on the desk of the CMIO, but other executives also pay attention to these innovation agenda items. But then following the imperative for innovation, what I want to convey to you is what is the challenge. And I'm just going to pick one challenge in the whole innovation process, not funding, not integrating it with the rest of the systems, and not getting providers, caregivers to adopt innovation, but rather a technical challenge, which is to bring all of the data to bear to these innovation ideas, because that's something that we can affect. And I'll talk about the challenge in doing that and then the solution for doing it better. After which we'll open the phone lines for Q&A for both Todd and myself. So, and I think you typed those questions in the panel that either Adam or that Adam described to you. But let me start off just by giving you a very quick overview of Verato in 2 slides, and then I'll turn it over to Todd to do the same thing. So Verato is a software company. We're located here in Washington, D.C. The weather's nice today, thank goodness. It's been really cold and snowy, not nearly as bad as the Midwest, where Todd is calling in from. But we are a software company, and we're the pioneers of this new technology called referential matching. And that phrase might not mean anything to you on the phone today, but it should. It's the next generation of patient matching technology. And it has some very important new benefits and features about it that are going to make the old version of probabilistic matching obsolete. So I'll get to that a little bit later in the presentation. But this new matching technology from Verato manifests itself in 2 different products something we call Auto Steward, and something we call the Universal MPI. And again, I'll put those in perspective, but this webinar is not intended to be an overt sales pitch. It's to make you knowledgeable about this new kind of technology and how it can be deployed. But we are a relatively new company with brand new technology. We are venture funded, and we've accumulated a very robust set of customers who are now conducting millions of identity queries against our referential matching cloud-based platform every single day. In fact, here's a quick view of some of our customers. You'll see a good number of major health systems. You'll also see some of the largest HIEs in the country, HIEs whose very business depends upon accurate matching at scale. And then a couple of the news items that we're very proud of here at Verato. Pew recommended referential matching as one of 4 solutions to the nationwide problem of patient matching. HealthX, one of our largest customers, has made the decision and has been very public about their decision to drop their IBM Initiate MPI product in favor of Verato's Universal MPI. HealthX being the largest public HIE in the country, so that's a very important move for them. Northwell, an important health system serving New York, Long Island, I believe, is using Verato to, in their words, annihilate the scourge of duplicate medical records. So we've got a number of customers, important customers, who are doing really dramatic things with our technology that they couldn't have conceived of doing before referential matching existed. Now, with that brief commercial, let me turn the podium over to Todd Stottlemyer, already introduced to you by Mike, and let Todd present a little bit of background of his company, and then we'll get to the content. Todd?
Great. Thanks, Mark, very much. And I will be very brief about CNSI. Just a little bit about our capabilities. I mean, our technology really focuses in trying to do 3 things. One, very importantly, drive better health outcomes for the clients we serve. Secondly, lower cost, and very importantly, empower consumers. And you can see a list of some of the very specific capabilities. We focus to a large extent at the state level, some federal, and in the future commercial, around our core claims administration platform. We are the first company with our clients to deliver the first modular Medicaid information system to be certified by CMS. We were the first company for successful MMIS migration to the cloud, and also the first company with a successful MMIS migration to the AWS cloud, again, working very closely for our clients. We are in a number of states today, serving a patient population of about 30 million. We also do some very interesting work for the federal government. A good example of that is our work at CMS to deploy a Medicare Part C managed care encounter system that up until this date has actually managed more than 5 billion encounters. So again, our focus is around the state and federal core claims administration, MMIS, and then the federal, working principally for CMS and other customers in the healthcare space. I think very importantly, as we think toward the future, that data visualization analytics line that you see under our capabilities, how do we take lots of data from different sources, whether it's claims data, clinical data, social determinant type data, familial data, bring that data together with the objective of real-time actionable information, again, to drive better health outcomes, lower cost, and very importantly, empower consumers. The next slide, slide 10, just gives you a little bit of an overview of how we view our ecosystem around consumers, providers, and payers. And again, I'm not going to get into the details, but this gives you really a visual about the CNSI ecosystem working very closely with our clients and our customers. The next slide is really our platform. Our platform system is called EvoBricks, and again, this system has been deployed for various state customers, the Medicaid Management Information Systems. You can see it's a modular delivery platform. It was the first modular delivery platform certified by CMS. We also build out a number of different applications. Rule It is our rules engine for the EvoBrick system. You see something called HealthBeat. That is an application. It's a real-time analytics application that in one state, for example, has 131 real-time active metrics for our clients to look at in terms of how the system is actually performing for end-user customers and actual beneficiaries of the program. You see ClaimSure down below. That is an application around the prevention of fraudulent claims. As you know, a lot of the way we pursue fraud today is we actually pay the claims and then we chase. This is actually to do just the opposite, where you don't have pay and chase. You can actually use this application to be predictive around fraud. It's a machine learning application that uses artificial intelligence, and it learns as more and more information populates the application. So again, a lot of work that we do is in various applications around the consumer health, real-time analytics, and also very importantly, making sure there's integrity in the dollars that are spent by our customers. So that's just a little bit about CNSI. I think very importantly, if you get to the next slide, this whole innovation agenda, and I think just a couple comments here. The healthcare system to a large extent has been transactional. Very transactional. You're sick, you come in, you get care, you leave. And what we really see today and going forward is a much more outcomes-based healthcare environment that focuses on health outcomes, again, empowering consumers, reducing costs, and also a system going forward that's very value-based and focuses on consumers. And so you see down below the consumerization of care, value-based care, moving away from a fee-for-service environment into a fee-for-value or value-based care type environment. Precision medicine, personalized medicine, certainly the benefits of that, how we can better predict and prevent disease, and if you get disease, how we can target your disease based on the molecular biology of your disease and making sure you have the right therapeutic based on who you are and not a broader population. And then finally, the whole coordination of care, which is absolutely critical to provide better care, higher quality, and also reduce cost, and again, extending care across the continuum. The next slide, I think it says that, I think it says correctly, that the innovation imperative, it's not an option in healthcare. As you know, as a country, we spend more on healthcare than any other nation in the world as a percentage of our gross domestic product, and yet we don't get the health outcomes that many countries do. So innovation is critical in terms of improving health outcomes and also lowering costs. The next slide talks about the consumerization of healthcare, and a couple thoughts on that. With all this data, with all this transparency that is here today and going to be with us even more so in the future, consumerization of care is really taking place. And what it really allows is for the ability for individuals to make better informed choices based on quality information, outcomes, and cost. And again, that is empowering the consumer to be able to make better healthcare decisions based on the information available around quality, outcomes, and cost. The innovation included portals and apps that drive patient loyalty. But one of the real challenges with the consumerization of healthcare is that patients really, as it says there, they will have firsthand visibility into missing and incorrect medical records. So we're giving them a lot more transparency, a lot more information, and the expectation is that you're going to have accurate medical records and you're not going to have missing or inaccurate medical records. So that's one of the challenges within the consumerization of healthcare. If you get to the next slide, again, I mentioned this earlier, but value-based care, again, focused on outcomes-based. You can argue that the system today is very transactional, that we focus on providing sick care. If you get sick, we take care of you, you leave, as opposed to really focusing on health. How do we keep populations healthy? How do we keep individuals healthy? How do we manage the health of populations around chronic care, which, as we know, contributes to the large percentage of spend in healthcare today? And again, how do we use technology to focus on health, not just on sick? And so you see some of the comments there. The innovation, clearly analytics, taking diverse data sets and diverse information, fusing that information, bringing it together to make real-time actionable decisions is very important. The personalization of care, consumerization, personal health apps, devices, real-time monitoring of vitals. Again, a lot of innovation taking place. And the challenge is that you need to aggregate all of these care events in this data, and those care events can come in many different forms, and that data comes from lots of different sources, and it's both historical and real-time, and that, again, is one of the challenges that we face, but great opportunity for innovation, obviously, in this space. And the next slide on personalized medicine, and again, personalized precision medicine, how can we better predict and prevent disease? If you do have disease occurrence, ensuring that you have the right diagnosis based on the molecular understanding of disease, the right therapeutics based on who you are as an individual as opposed to a population class. I mean, that's the real effort behind precision personalized medicine. I think very importantly there you see the social determinants of health, and oftentimes this is ignored in terms of how impactful social determinants are in terms of health. It's not just about your genomics and personal medical history, but the social determinants of health that really impact individual health, and that information and data is critical. You see Internet of Things and wearables, again, real-time monitoring around chronic disease, a real opportunity there, and significant innovations in clinical decision support tools and artificial intelligence. Again, the challenge is how do you associate all this data to the correct patient? And again, if we can't do that, then we're really missing the opportunity of the innovation that's taking place. The next slide talks, again, about coordinated care across the continuum, and certainly that was one of the objectives through the Affordable Care Act, that care takes place in lots of different locations for a patient, and you can see there's a list there of all the places where care may take place. The innovation has been around interoperability and integration, bringing data together, and certainly in a consumer-oriented type world, that consumer possesses a lot of this information and their own data about their own health. The challenge, again, is patient identity resolution. So a strong focus on coordination of care, extending the continuum of care from lots of different sources, locations, interoperability, integration, and very importantly, the challenge around patient identity resolution. So again, great innovation, great opportunity, but also a significant challenge. The next slide, again, this is, I think this really is the foundation of healthcare, is the innovation of data. And it's not just data, it's how do you take that data from various sources and turn it into real-time, actionable information that's going to impact quality, health outcomes, and again, very, very importantly, cost. And so you see down the left-hand side some of those innovations that we talked about, and again, all of these rely on patient data or patient information. And again, the patient data and information coming from multiple sources, and how that is integrated, fused, correlated, and then turned into real-time actionable information. So the good news on the next slide is that we do have lots and lots of data. As you know, there's been a proliferation of data. There's clinical data, there's claims data, there's genomic data, there's social determinant data. I mean, all that data, all that data is out there, but the bad news is we can't match all this data. And again, that is really critical. So when I think about the bottom line about patient matching that Mark's going to spend some more time chatting about, I really think about it being good for patient care, good for cost reduction, and very importantly, the real focus of what we're talking about today, critical for realizing healthcare innovation in the future. And again, that's the real opportunity that I see going forward. So let me turn it over to Mark.
Thanks, Todd. Yeah, so, many people don't realize it, maybe perhaps the CMIOs who are sponsoring these innovation vectors within a hospital system, provider in general, don't understand or realize that at the basis of all of this is clean access and complete access to patient data. And, quite frankly, patient matching and the predictivity and the accuracy of our patient matching infrastructures has largely been under the radar. Certainly the people in revenue cycle understand it because it impacts claims processing. But patient matching is going to become a CMIO issue as soon as he or she realizes that this data is the foundation for many of these innovations. So let me talk about the challenge of patient matching in general, and you can project that forward as to understanding that that also then directly impacts the ability to innovate. But this issue of patient matching, we've been living in a world, maybe represented on the slide you're looking at today, on the left-hand side is today. There's patient matching that exists today. It's embedded in EMPI products and EHR products, typically challenged to resolve patient identities through a relatively small set of closely knit application modules. Maybe one for labs, one for registration, one for reg cycle, one for the emergency department, but highly integrated and well-tuned. And even in this model, those of us who are in the HIM profession know that our patient matching is only working to a certain degree of perfection. And to the point where the technology is not perfect, we employ human beings, data stewards, to make up the difference. And quite frankly, this has become the status quo, and to some extent an acceptable status quo of having only marginal patient matching because its impact was relatively contained. What we see going on, though, is an emerging environment where the same EMPI or EHR product is not just interacting with its closely knit modules, but it has to do, as Todd was mentioning, it has to incorporate new technologies, new sources of data, new consumers of data that are part of the innovation agenda: biometrics, population health, customer relationship management, reaching out to customers or patients as if they were customers of the hospital system and not just patients. So this same EMPI is going to have to do a lot more work than it ever has had to do before. And it doesn't really stop there. That's just the beginning. On top of that are layered all sorts of additional innovation ideas, applications, systems, which are either going to be contributing patient identities or contributing data that needs to be tied to patient identities into this formerly highly integrated and highly tuned EMPI or EHR product. And the truth of the matter is that every one of these patient matching technologies out there is using this technology called probabilistic matching. It is the incumbent technology used. In fact, it was invented in 1969 at an IBM research institute, quite a scholarly document. It was implemented in the 1990s, perfected in the first decade of the 2000s, and we're still using the same technology here in the second decade of the 2000s. You see it in the EMPI products, the EHR products, the HIE products. They all, to some degree or another, use the same thing called probabilistic matching. And the sad story about this entire picture is what you see on the far right, and that is that the duplicate rate, which is our easiest measure of the quality of patient matching that we're doing, is, by all of the public surveys that are available now, indicating that it's getting worse and not better. In 2008, it was largely accepted that the duplicate rate was somewhere between 8 and 12%. Most recent, and that was, I think, in a HEMA report, a large HEMA survey. Most recently, Black Book did a very extensive survey and found out that most people were now reporting a duplicate rate of 18%. And so the question is, why is this technology seeming to get worse and not better? Technology should get better. I'll tell you what the answer to that is in a slide or two, but the short form answer to this question is we've pushed it beyond the limits that it can handle, and there's no room left to innovate this particular technology. So something new is needed. That's the punchline. But just by way of background, let me just very quickly tell you what probabilistic matching is so that you can visualize how it works today, and that'll help you understand the next generation of patient matching that I'll describe. But, if you have a human being and you have medical records and you're trying to tie a human being to their medical records, the thing that you use, the thing that is universally acceptable and usable everywhere, is the use of demographic data. First names, middle names, last names, street names, city, state, date of birth, social. All of these attributes, these demographics, a person can keep in their heads. They know who they are. They know where they live. And many of those same attributes have been encoded as the identifiers within the medical records in the EHR or the EMPI product. So So the question is how does the probabilistic matching work? Well, if all of this data is perfect, if there's no errors in any of the data, and there's no discrepancies in maiden names versus married names, or old addresses versus new addresses, or twins, or parents and children with juniors and seniors, this system would work perfectly. But there are errors within the data, and so because of that, there's this technology that's been implemented, probabilistic matching, which does a pairwise comparison of all of the elements, all of the demographic data, and if it matches completely correctly, it's given a 100% score. If they don't match at all, it's a 0% score. If there's a small misspelling in the name or the street or some other minor discrepancy, it'll get partial credit. And the probabilistic matching system adds up all of this partial credit to come up with an overall match score. This overall match score then is determined that to be either a no match, the person is a new patient, we don't have them in the EHR, far left, or it is a positive match, it's an existing patient, so let's not create a new medical record for him or her, or the really awkward situation where it's somewhere in the middle, it's an undetermined match, and it has to go to manual review. People have to make a human judgment as to whether it's the same person or not. And it's this manual review that causes all of the duplicate records to be injected into the system until they finally can get around to a person taking a look at it. Now, the situation with probabilistic matching is that it is entirely dependent upon the data and the quality of the data that it's working with. And I've already mentioned that if the data is 100% correct, then probabilistic matching is 100% correct as well, by definition. In reality, however, in Verato's estimations and in many of the published reports, upwards of 30%, in fact, at least 30% of the identity data in any given database is either errored or out of date or missing or has a default value to the point where it makes that person, that identity, unmatchable to a corresponding similar person or the same person. And because of that inherent error rate in all of our databases, and by the way, this is not just healthcare, this is government, this is retail, this is almost every industry suffers this issue of error rates within demographic data. What that does is it reduces probabilistic matching to about a 70% success rate. And when you add all of the new sources, all of the new patients that are being injected into these EHR products and EMPI products, that success rate begins to multiply on itself and begins to degrade the overall effectiveness. And so you see duplicate rates going from 12% to now 18% and probably getting worse in the future if we don't do something different. So let me tell you about the solution. The solution to probabilistic matching is not to try and make probabilistic matching better, but it's to switch to a much more powerful matching technology, as described here as referential matching. And very simply, referential matching, I'll describe it over the next 3 or 4 slides, give you time to absorb it, and then I'll pause and we can have questions and answers. So we're getting close to the final part of the presentation here. But referential matching is based upon 3 big ideas. One is the use of a very large reference database, a nationwide database of demographic data, to be used as an answer key. And with that answer key in hand, you build an algorithm, this referential matching algorithm, that to a very large extent mimics human logic. It does what-if analyses. What if this person that I think is the same as this other person, what if this person is actually the person's spouse or sibling? What if it's not the person? What other evidence would I find in my reference database to support that hypothesis? Because it mimics human logic, it can answer many more questions, just like human beings can do. And this, in that sense, it is indeed a form of artificial intelligence, ultimately delivering much more accurate matches as a human being would be able to do, and probably just as importantly, far less tuning required. And this tuning matters because when you highly tune a system, as soon as you bring on a new source, it breaks all the tuning and degrades the matching. And then finally, the third big idea with respect to referential matching is that it's entirely in the cloud, so that people can plug into it without having to deploy it on-premise in a massive way and tend it with with a team of IT specialists and data governance specialists. So more accurate, faster deploy. Let me give you an idea of the underpinnings of this new technology. The most important and fundamental thing is the existence of a reference database, as I've already mentioned. The reference database that Verato has built and that other referential vendors are thinking of building is one that's comprised of data, not from the healthcare industry, because then you've got a self-reinforcing errors that keep getting re-injected into the system, but instead it's a database of identity data that's culled from commercial sources, in this case from the credit industry, from the telephone company industry, and through all of the public records available through governmental and legal actions. But all of this data of identities flows into a reference database, billions of records, and those billions of records accumulate to well over 300 million identities. Now, in our database, over 350 million identities, but they contain a historical perspective of everybody's identity, upwards of 30 years. So it's not just Mark LaRow's identity as his snapshot of today, but it also contains the snapshot of my identity 5 years ago, 10 years ago, 15 years ago. So if you have a medical record that's 15 years old, it has no problem matching with the current version of Mark LaRow today. And it's a live database. It gets millions of updates per month. So as people move, change their names, the reference database is updated, and that update resource is then available to make the most recent matches, most up-to-date matches. And in fact, if you looked at this identity database in some detail, what you would see is that it is, as I said, it's not just a snapshot of the person, and it doesn't contain just their golden record of data. It contains a history of their data. If you have a primary home and a secondary home, this database would include both. If you had 2 or 3 different nicknames that you've used over time or you're currently using, this database would contain both or all of those nicknames. And the only way to put together this complex version of an identity database is through a lot of data science. And in fact, so much science that it would be entirely impractical for any healthcare system to assemble all of that expertise in the support of your EMPI. But because something like Verato's reference database is going to be used by many, many customers, we can spend a lot of money on a lot of PhDs to put together our reference database. And with that correct reference database, you have the ability to do a kind of matching that's unavailable anywhere else. In fact, this last slide that I'll show you here on the matching mechanics illustrates that point. I'll push the button in just a moment and you'll see some animation, but on the left-hand side you'll see how probabilistic does matching, and on the right-hand side you'll see how referential matching matches those same 2 identities. And what we've got here is identity A and identity B. It's the same person, but those little geometric figures there are meant to represent that we have different data about this person in A versus that same person in B. Perhaps you have a name, an address, and a date of birth in A, but you've got a maiden name and a new address and not a date of birth, but a phone number that represents the person in B. And that's what's kind of represented by the different geometries of these figures. But with probabilistic matching, those 2 identities would be overlaid on each other, and if the minor discrepancies between the data can be explained probabilistically, the EHR or the MPI could declare those to be the same person. However, if the changes are too great, maiden name versus married name, for instance, or new address versus old address, A and B couldn't be declared to be the same person just because probabilistically it's too implausible. Now, by contrast, on the right-hand side is referential matching, and here we've got A and B again, but instead of comparing A directly against B, we have this reference database down below in yellow, gold. And that reference identity has a much greater spectrum of data about this person. And that's what's represented by this more extensive array of sort of a spiderweb-looking thing. So instead of comparing A directly against B, you compare A against the reference database, you find out who it matches. You compare B against the reference database, find out who it matches. And if both A and B match to the same reference identity, then they match each other. It's no more complicated than that. But that idea is very, very powerful because it increases match rates considerably. In fact, the way I like to describe it here is with this Gaussian curve that talks about the spectrum of different identity challenges. And probabilistic matching does really well right down the middle. 70% of the use cases fall into a very common set of match challenges. And probabilistic matching is really well suited to determine those. Where it falls apart is where the identity differences are very subtle. Twins, husband and wife, siblings, parents and child, or very dramatic differences, people who do change their name and move when they get married, or some other major life change that causes their demographic attributes to change dramatically. And in those two wings, in the areas that are white space for probabilistic matching, you have to supplement them with data stewards, people who will apply human judgment and perhaps some supplementary research to make the decisions. Referential matching, by contrast, on the right side is different. It covers a much greater spectrum of identity situations. 90% can be automatically adjudicated with referential matching, leaving only a small percentage that still need human intervention and human judgment to make the case. So it's a really much more powerful matching mechanism than purely probabilistic algorithms. And it should be obvious to you now to see why. Now, unfortunately, the vendors out there are creating a good bit of confusion about referential matching. In fact, more and more of them are picking up this moniker, referential matching, to make you think that everybody has the same thing. And I'm here with you with this one slide just to kind of sensitize you to the fact that there isn't just one kind of referential matching. In fact, an awful lot of vendors that have large identity databases will tell you that data cleanup is a form of referential matching. And to some extent it is, in a very sort of minor way, and probably delivers only 20% of the value of full referential matching. Identity pinning is another kind of referential matching where you send an identity into a provider and they send you an ID back, a durable ID, they say. And this, too, does use a reference database, but it is just a pinning function. It's not a full matching function, and perhaps only is 40% as effective as full referential matching. And now the latest thing that people are talking about is this idea of data hydration, connecting your EMPI to a data provider, quote, a reference provider, and what they offer you is not an identity match decision. They don't offer you a PIN, but they'll give you more data about a given subject, a given person, maybe some more addresses, maybe some more phone numbers. And with that additional data, that data hydration, maybe your probabilistic matching system will make a better decision. And indeed it does, but again, not as good as full referential matching. Now, just to begin to close this out, referential matching in its full sense is delivered in two different forms. One is as a full MPI product, a complete replacement to your EMPI or a complete supplement to your EHR system that can operate full stop as the system of record for your patient database. And indeed, Verato has a product in that form. It's called the Verato Universal MPI that is entirely based on referential matching. But for those of our customers who aren't ready to swap out or change out an existing EMPI, or they certainly can't unplug the Epic Identity patient matching module that's operating and plug Verato into that same space within the Epic suite, there's another solution, and in our version we call it Verato Auto Steward, where Verato, or the referential matching vendor, doesn't take over the entire matching process, but rather acts as a resource for Epic Identity or Cerner Sorian, where Epic can send to Verato a pair of patients and says to Verato, we can't decide whether this is the same person or not, Verato. Can you tell us whether it's the same person or not, using your referential matching? So in that case, Epic or IBM Initiate or Cerner is still responsible for managing the patient database, but it's using the referential matching resource as a judge, as an alternative to a data steward, for perhaps 70% of all the tasks that would normally have gone to a human being can now go to a referential matching engine and make the decision instantly. And in fact, this final slide I'm going to put up for you just shows you some of the results of that exact kind of operation. What you see here is a chart showing you for a number of different EHR products or EMPI products, what percentage of the hardest matches, the undetermined matches that the existing system, the Epic or the Cerner, wasn't able to resolve, what percentage of those could Verato automatically resolve unambiguously and therefore didn't have to be sent to a data steward? And if you look across this graph, you'll see it's anywhere from 50 to 75% automatic or auto data stewarding. So the point here, if I was to sum it all up, is that the innovation agenda does depend upon data. Data depends upon patient matching, and our existing probabilistic matching systems are not good enough. Now, my final slide I'm going to put up here, I have to do a small disclaimer. I allow my marketing department a bit of latitude in producing the last slide. I just ask them to keep it within as good taste as they can, but they often try to embarrass me a little bit with a little bit of out-of-bounds material. So if you are suffering from poor patient matching, if it's preventing you from several important innovation agenda items, you can cure your innovation-itis. You should ask your doctor about Verato. It's a revolutionary new treatment for this ailment. And the small print says the side effects may include lower duplicate records, more efficient operations, lower costs, fewer HIM headaches, and a newfound confidence in your patient matching capabilities. But do not use Verato unless you are sure you want to innovate, and do not operate heavy machinery while using Verato, because Verato is a cloud-based solution. So I get full points for having delivered their slide. So I win this particular battle with my marketing group. But once again, look, we would encourage everybody to join the patient matching revolution. It is important for the innovation agenda, and frankly, you need to put in something new to change the equation. The existing technology is no longer going to be good enough. Now with that, let me truly stop speaking and turn the podium over to Mike and ask if there are any questions that the audience has teed up for us.
Thanks, Mark, very much. Appreciate you and Todd and your presentation. Fortunately, we became aware that we had a little technical glitch there for a few minutes and lost our audio with some of you, so we apologize for that. So two things I want to tell you. First of all, the full recording, including all the audio, will be available after this event as an archive that you can download and view and listen to on demand. Okay. The second thing is, though, some of our audience members have asked Mark if he wouldn't mind going back briefly through slides 22 to 30 and just give a real quick overview for anyone whose sound cut out. If you had heard it before, we apologize for a little bit of redundancy, but we want to make sure everybody has a chance to hear it, and then we'll jump in with any additional questions that you have. So, Mark, I'll let it go back to you.
So I'll do the 4-minute version of these 8 slides. Okay, all right. I'm sorry about that for everybody. I was speaking blithely forward. So if you did drop off right here, what I was making the point here is that probabilistic matching has been the technology that we've all depended upon for now 20 years to match patients. It was invented in '69. It's used pervasively in almost every technology. Even though you might not know it, it's in there. It's embedded in there. But the sad truth is that it's not getting better with age. It's getting worse. It's getting worse because probabilistic matching has not undergone any innovations, not because vendors are lazy, but because there's no room left to innovate. There's no mathematical space left to make these algorithms work better. The next slide represented very quickly how probabilistic matching works. I won't go into the full dialogue I did previously, but look, the way probabilistic matching works in very short form is it takes the demographic data that a person has in their head and the demographic data encoded in a medical record, and in a probabilistic matching engine, it compares everything, first name to first name, middle name, last name to last name, And it ultimately derives a score, a likelihood that these are the same people despite discrepancies that might exist in their data. And that score then results in either it is a determination that it's a new patient, quote, no match, it's an existing patient, yes match, or it's undetermined, meaning the probabilistic matching system can't quite decide whether it's the same person or not. And frankly, this number, can't quite decide, can be upwards of 30% of all of the match requests, and those things go to human beings to resolve. I very quickly made the statement that the reason probabilistic matching can't get better is because it's entirely dependent upon the cleanliness of the data, and that identity data in almost every identity database, healthcare or not, is about a 30% error rate, resulting in about a 70% success rate, which is what's attributing to this decrease in duplicates performance. And then very quickly, and again, I know we're pressed for time, so thank you for hanging in with us, I also made the claim that referential matching is different because it's based upon the existence of a gigantic reference database of identities, a new kind of algorithm called referential algorithm, not probabilistic, and based in the cloud. I made the point that this reference database is sourced from a number of orthogonal data sources, and it's a live database with a long history of data about every single person so that it can make identity judgments impossible otherwise. And in fact, Verato and other referential people spend an extraordinary amount of money building this reference database so that you, customers, don't have to, but yet you get to take advantage of all the precision that exists there. And then I will finish with this final slide. I won't go all the way to 30, but I'll finish with this final slide because it animates well and makes the point. That is that probabilistic matching does pairwise comparisons of two identities. A and B are the same person, but in probabilistic matching, the overlap is not enough to probabilistically declare that to be the same person. Maybe they moved and changed their name. Whereas that same test, those same two people, A and B, instead of being compared to each other, with referential matching, they don't compare to each other, they compare themselves to the reference database. A maps to a person in the reference database, B maps to a reference person in the reference database, and if they map to the same reference identity, they map to each other. And if you take nothing else from this session, that one fact is why referential matching can always match more people than probabilistic matching. So let me stop there and again open the lines up for any questions that you might have.
Great, thank you, Mark. Appreciate your going through that again in the abridged version. So let's get to some questions from our audience. First question, our audience member wants to know, any thoughts about applying this technology to cleaning up the patient problem list, which is a mess sometimes when outside records come in?
Yeah, maybe I'll take that one. The patient problem list is probably the list of undetermined matches. I'm not sure if Mark LaRow is the same as Mary LaRow. My algorithm can't decide it. I need to send that task to a human being to determine. And the answer is absolutely yes. I mean, that's precisely what referential matching is good at. It's you give it Mark LaRow and you give it Mary LaRow, probabilistic matching at the same address with the same phone number, probabilistic matching would say that indeed is the same person, only one letter difference in their names. But in reality, Mark LaRow and Mary LaRow are spouses that live together and have the same phone number. Referential matching would be able to figure that out. And that problem occurs in the purely clinical sense with patient records, but it occurs in spades when you're bringing in external information, as the questioner asked. Social determinants of health are notoriously difficult to match to patient records. Any other external data, because it's not governed as well as healthcare data is governed, or as tightly, the match decisions are much more varied and ultimately therefore difficult.
That's great.
Anything else?
Let's go to our next question now. Our audience member wants to know, how does patients increasing access to the medical records come into play with respect to patient matching?
I'll take that one too, although if Todd wants to chime in, he certainly may. Look, we've seen this with a number of our customers. one of the reasons for bringing in referential matching is solely because patients now have greater visibility into their medical records. And what becomes very visible to a patient who's viewing their records through a portal or through an app is the fact that some of their records are missing, and they're missing because they're duplicates in the patient repository. And this is truly embarrassing for hospital systems because they get questioned all the time now directly by patients. Why don't you have my appendectomy? Why don't you have my, such and such test in my medical records? I know I was there. And to a very large extent, hospital systems are now being judged by patients on their record keeping. Never before happened, but now with this greater visibility, it's happening.
Yeah, this is Todd. I would agree with Mark completely on that. And again, I think there's an expectation that's being set if we're going to have electronic medical records that patient medical history is all going to be there. And if it's not, that again, going back to the consumerization that's taking place and consumers making choices, quality, outcomes, cost, expectation that medical records are all going to be there. I mean, that's really a quality metric and an expectation. So if they're not, then that's a way to drive a potential patient consumer away from your system to somebody else's system.
Great. Let's go to our next question. And Todd, this is probably a good one for you because you touched on this whole notion of scale. You said that referential matching technology is scalable. Can you elaborate on that?
That was actually Mark that said that, but
I better take that one. Well, it's simply this. With many, many more sources feeding a matching system, a typical probabilistic matching system has to compare every identity record to every other one. It's an N by N comparison problem. And so the more sources you have feeding your MPI, the greater the likelihood that you're going to inject an error through all of those tests that you have to do. Is Mark the same as Stephen LaRow? No. Is Mark LaRow the same as Mary LaRow? Possibly. Is Mark LaRow the same as whatever? So the more sources you have, that means higher scale, the greater the chance that you're going to inject an error with probabilistic matching because you have to test every record against every other record. With referential matching, you don't test every record against every record. You test every presented record just to the reference database. And so the problem reduces to a 1 to N matching problem, which has a much lower likelihood of creating an error and therefore injecting it into the system for everybody. I would have done better if I'd had slides.
Great. Let's go to our next question. Our audience member wants to know, does performance suffer with referential matching by using the reference database?
No. Oh, yeah. That's an interesting question. Yeah, I guess with the size of the reference database, one might assume that it's slower than a smaller database. But the answer is no. I mean, look, anybody like us that's managing hundreds of millions of identities is running in a cloud infrastructure with hundreds and hundreds of servers operating in parallel. So, in fact, referential matching is being used in a real-time manner with sub-second match times so that they can be used at the portal. Right when somebody's logging on, you can hit a referential matching system and expect to get a result at the speed by which somebody interacts live with a portal.
Okay. Well, that is really all the time we have now for questions. I want to thank our audience members once again for bearing with us on a little technical problem. We're glad that you stuck with us throughout the program. And again, wanted to remind you that there is an archive version. There will be an archive version of this entire presentation with full audio and video that you can download and watch and listen to on demand. I do want to take this time to thank our presenters, Mark LaRow and Todd Stottlemyer, for their presentation, for answering questions today. We do appreciate the input that you've shared with us. Once again, want to thank Verato for sponsoring today's program. We do appreciate their support. And last and certainly not least, We want to thank all of you who attended this program today. We know that you have very busy day jobs. We're glad that you could spend a little time with us. We trust and hope that you got some good insight from our program today. And we certainly hope that you'll join us for a future web seminar brought to you by Health Data Management and its sponsors. So on behalf of our sponsor, our host, and our presenters, thank you all again for joining us. We hope you have a great day, everybody.